When we look at guidelines for treating rheumatoid arthritis, a lot has changed over even the time I've been in practice. So, in the days gone by, we used to think that the treatment was worse than the outcomes of the disease. The side effects of treatment might be sort of toxic, and the disease maybe wasn't so toxic. We learned a long time ago that if we treat effectively early, put our disease modifying drugs in there at the very beginning of the patient's journey, that we can actually put more people into remission and keep them there. So we inverted the pyramid. The old pyramid was anti-inflammatories like naproxen kind of drugs. Then it was drugs that were mild disease modifying drugs, and then drugs like our anchor now, methotrexate. Now we start with methotrexate if anyone has what we'll call poor prognosis rheumatoid arthritis. We start at more effective doses. We add drugs or change drugs fairly quickly. We now treat to a target. And with all these guidelines in place, there's good and bad news. The good news is we get more people in remission, there's less work disability, there's longer survival, better quality of life. The bad news is people still can flare. We don't yet cure rheumatoid arthritis, but we never talked about remission when I practiced early on. And now my goal in early rheumatoid arthritis, like in our Canadian arthritis cohort, the CATCH cohort, our goal is rapid, sustained remission. So with just using our common drugs that we've had for a long time more expertly, we've done a way better job. The other thing that has changed in the guidelines is we have access to a lot of drugs. So if a patient isn't doing well on what we call these conventional synthetic DMARDs, the methotrexate, hydroxychloroquine, sulfasalazine, leflunomide kind of drugs, there are advanced therapies, biologicals or oral drugs as well, targeted synthetic. And again, they can help to put someone back into remission or get better disease control and have less damage over time. All this again translates that there's less need for surgeries from damage of your rheumatoid arthritis. But there's still unmet need. People live with fatigue, sometimes chronic pain. The biggest risk of pain is pain. So having pain like fire in lots of joints, say 12 swollen joints, that can go more widespread over time. And we've also done research on that to try to help people not get into widespread pain and to realize that at some point it might not be active inflammation, and we have to acknowledge and accept the pain, but also try to treat it effectively with drugs that might not be treating inflammation added to their anti-inflammation medications.